Hello, class. Today I would like to talk to you a little bit about catheter-associated urinary tract infections and how we as institutions in healthcare are still chasing zero to bring down those numbers of hospital-acquired infections. Reducing the hospital costs for catheter-associated urinary tract infections is in the best financial interest of hospitals, and it is in the best healthcare interest of our patients. Many efforts have been made through the years to discourage the use of the indwelling urinary catheter device, including the recommendation guidelines by the CDC in 2009 for preventing the catheter-associated urinary tract infection. In 1982, Dr. Camille Newton invented the PureWick system for the female external urinary incontinence, forever changing how we would think of this problem for our female patients. In this female external collection device, by placing a cloth-covered flexible wand in the labial fold and connecting it to tubing, which runs to low suction at the bedside and away from the patient, it collects urine into a canister when the patient voids and keeping the perineum clean and dry, reporting accuracy of this at 95%. So what is the significance of our problem? The significance of our problem is the cost that is absorbed by the hospitals, the pain and suffering for the patients, and deaths that are associated with the catheter-associated urinary tract infections. CAUTIs are the most prevalent infections in healthcare. Almost 75% of our hospital-acquired infections are catheter-associated urinary tract infections, and almost 15 to 25% of our patients are going to end up with an indwelling catheter at some point in time. That cost that's incurred by our institutions can average $7,000 for inpatient and up to $10,000 for ICU patients. So my PCOT question became, in the acute med-surg patient, what is the effect of the female external collection device on decreasing urinary tract infections compared to indwelling catheters for 12 weeks? What is my setting for this change? I would really like to focus on these patients that specifically hit a criteria that would be the most beneficial for use. So all female patients over 18 and who meet these following criteria: the acute retention, critically ill. We also want to facilitate wound healing, particularly those sacral wounds and those moisture-associated maceration breakdown. The prolonged immobilization patients, the quadriplegic, paraplegics, those that have difficulty moving around, and improved comfort during those last days of life. So my search strategy began with the University of St. Augustine's library system with PubMed, Ovid, Cinval, and the Web of Science. That netted me about 341 studies, which was able to reduce down to 17 when my first exclusion criteria were used to eliminate a majority of these. So duplications, things that were too far out of date. My key words that I used are here, but really what I focused on and had to really narrow it down to was the external female collection device, or the FECD. So then by using only peer-reviewed studies, anything that was full text, English, and not more than 5 years old, led me down to 8 studies in which I was able to use. That led me to looking at those particular 8 studies carefully, 4 of which were abstracts. So then that left me with 4 solid studies in which to base my information. So what was the synthesis of this literature? These graphs you can look at in your own leisure, and then I'll do a synthesis of them too. But what it came down to was looking at the number of inpatient days with the female external collection device versus the indwelling catheter. What was the efficacy of reducing those catheter-associated urinary tract infections? Different recommendations were made. All of them were qualitative studies, which was helpful, but what I did find is that all of them were retrospective. They looked back at a period of time to see if it had been beneficial. I would like to do this going forward in a live simulation of this issue to see how we can make changes along the way to best benefit our patients. So, my practice recommendations are to use the female external catheter device in place of the indwelling catheters for specific situations, as we mentioned before, and that is most beneficial for the patient. I would like to do a survey when they come in on admission for those female patients, explaining the system and helping them understand what their options are if in the event that they need an indwelling catheter, this might be an option for them. And we can try to capture those patients before it becomes a situation where we just need to get it done. By using the electronic medical record to track those patients each night at midnight, we can count how many patient days we have in that 12-week period for the female external catheter device and the indwelling catheter, and then compare those two numbers for our number of catheter-associated urinary tract infections or urinary tract infections during that time. So my evaluation criteria became the therapeutic intervention of the FECD versus the indwelling catheter. And does this patient meet those specific setting requirements as was previously listed? And what were the number of days with the FECD versus the indwelling catheter? So the change model that I thought would best fit this is the change curve model. The stagnation occurs when we have a status quo. We've hit a stagnation when we no longer are making an impact on our identified problem, which in this case is the urinary tract infections, or the hospital-acquired urinary tract infections. The preparation would be recognizing that there's something different that we can use and trying to make an impact with that. That would include educating of the staff in regards to what the criteria are, what it means to have one, and how it's properly used. Also, it means preparing the patients, which is why I thought doing a survey at the beginning and admission, and then doing a survey at discharge for those patients who received them would give us some real-life actuality and some real-life data to use to show a preference for the female external device versus the indwelling, and then again by reinforcing that with our decreased catheter-associated urinary tract infection numbers. So then we implement the issue, we implement the change by defining our 12-week period and starting from that day, and then doing a counting at each night at midnight of how many female external devices we're using versus indwelling, and then at the end comparing those numbers to look at our CAUDA numbers. The determination is what that would be called. And then fruition would be when we see the impact of the change that we've made and decreasing those numbers. So our data would be, as I've said before, the time would be the 12-week period. And then the collection tool that I would like to use for analysis is the T-type assessment tool, which is pretty straightforward in giving us a firm objective number for impact of change. So if I were presenting this to the general public or to my colleagues, as I am here, I would like to do this in a poster or presentation, personal presentation, or even in a paper. I could present that to the healthcare systems that I visit. I am a clinical nurse instructor with a local university, so I don't work in the facilities themselves, but I do visit quite a few different areas, and I think that this would be beneficial in quite a few of those. I go from nursing homes to acute care with LPN students and training them to use their new skills to better or advance their careers. So I could also present this in Infection Control Today, the Journal of Wound Ostomy and Continence Nursing, Ostomy and Continence Nurse Society, or any wound care conference in the area. So what is the plan moving forward? I would really love to see this coordinated with our nurse practitioners and our physician assistants as a first resort use instead of automatically going to indwelling sometimes. The educational opportunities are clear. In doing some of my research, I realized that education was one of the factors that sometimes made this system not work. It is part of a solution. It is not the whole solution. The part that it plays is vital by not actually inserting the indwelling catheter, we are making a major change and a major impact on reducing the effect of the urinary tract infection. But there's many aspects that go into that, along with perineal care and hydration, the other factors that come along with urinary tract health, not just accurate output. So including education for the patients is also necessary. Again, that pre and post survey would be beneficial in regards to that. But the effect of educating the staff on the proper use, the proper technique, the proper utilization of it, and the proper bundle, the maintenance bundle that goes along with that in ensuring that we reduce those numbers of urinary tract infections, which would also affect then implementing nursing protocols to reflect that. So, in conclusion, the addition of the PureWick female urinary collection device and other devices of its kind have made a very impressive addition to the fight against catheter-associated urinary tract infections, because it eliminates the catheter part of it, which I think is absolutely fascinating. When I first was introduced to this system several years ago, I was absolutely floored by the idea of it and why we had not thought of this 40 years ago, before we had to be forced to do it with Medicare reimbursement. It is such a dynamic input and has made such a dynamic effect in reducing these numbers, but utilized effectively with all of the other aspects that go with it can make even a more impact. So providing options for our female patients that previously were unavailable, that's an amazing concept. Males have had the option of the condom catheter for a long time. Certainly perineum care comes along with that, but this option for the female external device is groundbreaking. So education, again, is still the key. We have to properly use that equipment. We have to coordinate it with our aseptic techniques, and we have to use it with our maintenance bundles to have an effective outcome. Here are my references. Please feel free to browse through these, and I hope that you all have a wonderful day and a very Merry Christmas. Thank you.